Okay. All right. Who has these tracings? Can you hear me?
Yeah, we can hear you.
Okay, but nobody has this tracing. Okay, we can move on. Let's see this one.
Yes, it's mine.
Okay, so it's your turn.
Oh,
So only one question that I'm asking. If I'm pressing this one, can you see the magnification? Or you see nothing?
no, I can see the tracing.
Okay, only the tracing, but you do not see how I magnified it.
No.
Okay, good. That's it. All right. Now, it's your turn.
Yes, so
Step by step.
first if I check the rhythm is regular because the R intervals are constant.
Mm-hmm.
And for heart rate, there are about 4.5 squares between R waves, so
Mm-hmm.
it's about 67 beats per minute, which is normal.
Okay.
And for the axis,
Mm-hmm.
both lead 1 and AVF are positive, so it means it's between 0 and 90 degrees.
Yeah, but because AVF is a small one, it's almost
Yes.
zero, you can assume that
So it is around 0 degrees.
very good, around zero. Okay, good.
And if I see the P wave is always followed by QRS complex.
Very good, very good. Okay.
And P wave is positive in lead 2 and negative in AVR.
Yeah, it looks like
So
small,
it
but
is a sinus rhythm.
very good.
And PR interval is constant.
Mm-hmm.
So it is also normal.
Mm-hmm.
And if I see the QRS complex, I think it is slightly widened, more than 0.12 seconds.
I do not think so. First of all, you have to find the beginning and the end of the QRS complex. Okay, doesn't matter which part I'm going to use it. Okay, I will show you. Okay, let's focus on lead number one. Okay, lead number one. As you see here, this is the beginning of the QRS, and I will assume that this is the end of the QRS. So relatively, the QRS is not wide. That's narrow. That's okay. That's doesn't see. It's narrow. All
Oh,
right.
yeah.
Okay.
Well, I thought it was like pathological QA before the QRS.
Okay. Let's see. Where can you see pathological Q wave? Okay. So the QRS is narrow. I will assume that QRS is narrow. Now you said that we do have pathological Q wave. Which lead that you do have, or it looks like you see some Q wave?
Maybe lead 1, 2.
Lead one, there is no Q wave. Lead one, there is no Q wave. See, if I magnify it, I can magnify it, but there's no Q wave. Not at all. The Q wave, if you want to see Q, that looks like as a Q wave. Okay, the first negative wave, like it's a Q wave. But here, there is no Q. Okay, there is no Q either. Here, you can see a QS complex or the QR complex in lead number 3. But to say that we do have a pathological Q wave, you have to have this Q in two consecutive leads. All right.
Yeah.
So, for example, if you do see, I start to draw it. Okay. If you do see, this is a hexaxial system. Okay, let's draw the hexaxial system. I'll try to draw it. Okay. All right. Okay, good. Now, so if you do see Q wave here, okay, for example, you do see Q wave here, you have to have a Q right here in AVF, all right? If you do see Q wave in AVF, you have to have a Q or in lead number 2 or lead number 3 as well. Or if you do have for in case, for example, lead number 1, you have to evaluate AVL or lead number 2, but mostly AVL that is close to each other. Okay. Only one Q doesn't mean anything. Now, to see whether this Q, for example, in lead number 3, this is due to, for example, the anatomical situation, you can ask the patient to take a deep breath. And this way, the diaphragm is moving and the axis, the anatomical axis is shifting, and this Q can disappear. That's another possibility to show that this is not a pathological Q wave. So here, I do not see any pathological Q wave in any lead. Now, what pathological Q wave means? Can you tell me?
Pardon?
What is the pathological Q wave?
It means necrosis.
Yes, but how do you know that that's a pathological Q wave? It has some kind of criteria. First of all, it should be wide. Yes?
Yeah.
How wide should be? At least 1 millimeter or more. Okay? So it meaning that, okay, it should be more, or no, this is less, more, not, almost tried it, okay, 1 millimeter. All right? This is one thing. Another one, it should be deep, okay? Deeper than normal. What does it mean? It says that 1/3 of the R, but I would say that go for 1/4 of the R, okay? Of the R wave. Or another thing, that you do see Q where you should not see Q, okay? Okay, should not be. Another one, if somebody had a Q and the Q deepened, okay, these are the criteria for having a Q wave, and you have to have Q in 2 consecutive leads. Okay, this is how you can interpret a necrosis. All right.
Okay.
Now, in this situation, what we had here, there is no pathological Q wave at all. Okay, now you can go further.
Now, if I check the ST segment,
Okay, first of all, you can check the size of the R wave. Okay, let's see. This is a little introduction to the hypertrophies. Okay, you know that in the chest lead, it should not be bigger than 25 millimeters, or in the chest leads, for example, in the chest lead should not be more than 25 millimeter, or in the limb leads, it should not be bigger than 10 millimeters. All right. Now, and you do not see this one, and you do not see that any big R wave in V1. All right, so there's no sign of ventricular hypertrophy. Okay.
Okay.
This be the next seminar, the hypertrophies, but I do not think that we do have to have a seminar for the hypertrophies because it's relatively easy. This is why I'm giving a little introduction to hypertrophies. Okay, let's move on. Now the ST segment, you can discuss it.
Yes, I think I can see some ST elevation,
Where?
maybe in lead 2.
Okay, I would say that, okay, this is a notch, it's very characteristic. So lead number 1, lead number 2, all right? And AVL, can you see this AVL?
Yes.
You do see an AVL, all right? And if you do see here, I would say that maybe you do see in V2, V3, V4, V5, V6,
Yes.
all right? So relatively, if you want to see where we see this, we see in the anterolateral lead, okay? And it looks like in the inferior, we do see a little part as well. So relatively a very huge area that we do see this ST elevation, all right?
Yes.
And then other very important one, if we do this little notch that you do see here. Okay, almost everywhere you do see this little notching. Okay.
Okay. So So I think it is infarction, inferior and anterolateral infarction, myocardial.
No. Okay, that's a tricky ECG. Tricky ECG. First, if you do see some kind of ST elevation, you go for the MI, ST elevated myocardial MI. And you know nothing about the anamnesis of the patient. It has some chest pain, and of course, it's not radiating anywhere. But because you do see these kind of alterations, so a lot of ST elevation in different leads, because it involves the inferior and anterolateral, relatively is a huge ST elevation occurs here, that you assume that can be the sign of pericarditis. Okay, this is not so common, but you can have pericarditis. So if you do have ST elevation in different areas, in different, let's say, coronary supplied areas, you have to think about pericarditis. And when you do have the midterm, of course, you do have the anamnesis of the patient as well. All right. So, and if the patient is complaining of, for example, uh, chest pain in a supine position and during deep inspiration, you have to think about that, for example, the pericarditis can be the sign. Okay?
Okay.
All right. Okay, dokie. Thank you. And we are moving on. And let's see the next one. I think it's, yes, 103. Anybody?
Yes, it's mine.
Okay. I think you
Uh,
already prepared some presentation. Do you want me to let you?
yes. Yes,
Okay.
I can share my screen.
Okay, share your screen. Try to share it because I think I can let you to share your screen.
Okay, I'll send the request.
Okay,
Okay.
let's see how does it work.
Can you see it?
No, that's my problem. I don't see it, so I will
Oh,
stop my sharing. Okay,
okay.
now I do see it. Okay.
Okay. Yes, so I will start with the rhythmicity. So to me, it appears rhythmic. There is also P waves before every QRS, and P is positive in lead number 2 and negative in AVR. So we know that the origin of the impulse is from the sinus.
Mhm.
So we have a sinus rhythm. The heart rate is around 100 beats per minute because we have around 3 boxes between the QRS complexes. So it is a normal sinus rhythm, and the QRS complexes are also narrow. For the axis, QRS is positive in lead number 1 and also in AVF, mainly positive, I think. So
It's or equiphasic. You can see this
yeah,
equiphasic. Okay.
yeah. So the axis is normal, and I think that lead number 2 is the most positive out of all of them. So then it is followed by, I think, lead number 1. So I think the axis is around like between 40 and 50 degrees.
Mm-hmm.
Um, okay, so the next thing I noticed were the ST elevations in the precordial leads, namely V2 to V5, which we
Mm-hmm.
can see here. I kind of
Mm-hmm.
highlighted them. And um, I also thought they were pathological Q waves.
Mm-hmm. Mm-hmm. Now that's a pathological Q wave.
Yeah.
All right, and you do see in at least 2 consecutive leads, but you
Mhm.
do see in V1, V2, V3, V4, and all right, in the chest lead, the V5 is the first lead where you can see Q wave normally. All right,
Mhm.
in and maybe sometimes it's V1 as well. You can see QS complex, but most there is no Q in V2, no Q in V3, and no
Mhm.
Q in V4. But here you do see it. Okay.
Mhm. And I also noticed T inversion in lead number 2 and V1, for example.
Okay, all right, okay. Now let's see it. I do not think that that's a T inversion because
Okay.
let's see.
Hmm.
I accept that this is a T inversion, okay?
Okay.
But you should see the T right here, all right?
Hmm.
Because that one is parallelly recorded. So this is not a Q, not a T wave. That's a passive is a QRS complex.
Hmm.
Okay, somehow the ST and widening a little bit is due to the ST elevation. So this is what you have here, the ST elevation that you can see somehow is altered as well. So this, I don't think that is a T inversion.
Okay.
Because it should be a little bit further from the QRS complex, the T wave. Okay?
Okay. And so because of the chest leads that are involved, I thought that this was an acute anterior STEMI. Because it's the precordial leads that are involved. So yeah.
Or anteroseptal STEMI, that's okay, because in V1, V2, that's a septal leads, and up to V4 is an anteroseptal. Okay? And what else? What else?
I wasn't entirely sure, but
what can you see in V1? Tell me, what kind of complex you do see in V1?
a widened QRS?
No, you do see a R
RS.
wave.
Oh,
R
okay.
wave. Okay, an R wave. That's a QR complex. Now, when can you see, because normally this is how a V1 looks like. Yes, this is how normally V1 looks like. Now, if you do have a pathological Q wave and ST elevation, that should be something like this. All right. And this is not. So it's different one. Here you do see an R. Why do you see a big R in V1, V2? And
is it because of I'm not sure if it's a posterior.
In posterior, you do see an initial R, not the second one. This looks like the second R is big. So if you calculate the intrinsic deflection or ventricle activation time in V1, so that's meaning from the beginning of the QRS complex till the last R waves. See? In normally, what we learn, normally this be less than 0.04 or so. And this is wider. What does it mean when the ventricle activation time or ID time is elongated in V1?
Bundle branch block?
Yes, which one?
I think right?
Yes, exactly. That's
Okay.
right. Bundle branch block. See? Now, of course, you are expecting this kind of pattern to
Yeah, I
have
was looking
right.
for the
Yes,
RSR prime.
yes, but this is altered by necrosis.
Okay.
That's the problem, see? And if you do see a big R wave, especially the next one, and you see that the ventricle activation time is elongated in V1, always think about right bundle branch block. Another thing that can cause a big R wave in V1, that's a right ventricular hypertrophy. But when you do see the right ventricular hypertrophy, okay, now I'm drawing, maybe I delete this one, the old one. Come on. Okay, that it's meaning that you can have, for example, this kind of this kind of pattern in V1, and in V5, V6 you do see that's a right ventricular hypertrophy. Okay, so it looks like that it's opposite exactly, because normally you are expecting the big R in V5, V6 and the deep S in V1. However, if the RS ratio is bigger than 1 in V1, that meaning you do have a right ventricular hypertrophy, and the RS ratio is less than 1, for example, in this situation on V5, V6, that means right ventricular hypertrophy. But this is not a right ventricular hypertrophy because you are missing the S wave, the deep S wave in V5, V6, plus the initial R is vanished due to necrosis. So I would say that's a right bundle branch block. Okay, and now you can explain what can it be. That's an S wave. See, that's an S wave is due to the right ventricle, right bundle branch block.
Okay.
Good. Okay, now you won't have problem with the meter for sure. Okay, now, all right. Let's go back to my screen. Okay, and let's see. Okay, 104. Anybody has 104? Huh? No? Okay, 105? No? 106? Who is the next one? Let's start with that one. Who has the next number? And which is the number?
I think I have the next number. I'm 112.
112. Okay, I'm going for 112. Okay. Yes, that's it. All right.
I do have
Now,
my own annotations, so
all right, let's try to share it. Okay, let's try to, maybe we can share both of us. Now let's see. Share it. Do it. Do the share.
can you see it?
Not yet, so I think it doesn't work this way. I don't know why. Maybe I have to. No. Optimize for video sharing. No, remote control. No. Okay, I stopped my sharing. That would be. Okay, not. Wait a minute. Okay, I try to share my as well. Yes, but I do see only mine. Yes, you do see only mine sharing. Yes, but you don't see another one. Okay. All right, let's go for this one. I stop my sharing.
Okay. All right, then right off the bat, we try to evaluate rhythmicity, and this trace looks rhythmic. If we try to calculate the heart rate, it's about like 5.2 large squares between like the RR interval in lead 2 and then also in lead 1, it's kind of also the same. So that's like a heart rate of about 58 beats per minute, which is bradycardia. And if we evaluate AVR, we do have a negative R wave or rather QRS complex, and we have a positive QRS complex in lead 2, which is normal. So we would assume that this is sinus bradycardia. And then when we try to evaluate the electrical axes, right, we look at lead 1 and AVF, and both are positive. So we know that the electrical axis is within the normal bounds of 0 to 90. If we try to give an approximation, right, we can see that lead 1 and lead 2 are about the same. So we would say that maybe it's between them, so about like 30 degrees.
Very good. And you do see lead number 3 is equiphasic, so it's proving your
Yeah, also
hypothesis.
lead 3 is
Okay.
physics, so you could figure it out that way. So then I would look for the P waves, and we can see that they are present in basically all the leads. So there's no problem there. And the QRS complex is also narrow, just like it's supposed to be, so there's no issue there. And then right off the bat, what caught my eye as well was this within the chest leads. We can see ST elevations in chest leads V1 to V4, right? Which is usually indicative of a anteroseptal myocardial infarction. I thought that this was because here we have a Q wave abnormality, but you said that if we only see it in one lead and not in the related leads that are adjacent to it, then usually doesn't mean anything. So
Except the ST elevation.
yeah, the ST elevation, however, is definitely
All right.
present. We also, I didn't know how like relevant this was, but I do see here, I think this is a biphasic T wave.
No, that's a T wave. That's a normal T wave. You do
Okay.
have a little ST depression, but not
Yeah.
too much. So it's about 1 millimeter or so. But it's pathology, but that's the sign of ischemia or anything.
Yeah,
But
that's
I
what I
don't.
thought it
Okay.
was.
Yeah. Okay, no, then nothing else. What you do
Okay.
see and what you diagnose, it's correct. It's enteroseptal STEMI. That's it.
Okay. All right.
So
Thank you.
relatively, if you want, that's a hyperacute STEMI, but doesn't matter. So it's only the ST elevation. To hyperacute or acute, this is good to decide whether you use a stent or any thrombolysis or anything therapy to dissolve the clot. And because that you do have an acute, and depending on the stage, of course, the Q is deepening, deepening, deepening when the necrotic area is getting bigger. But this is only the enteroseptal STEMI. If you say that's fine, or in hyperacute, but this is not a clinical, let's say, approach that a hyperacute or anything, but you can see it's in this situation. Very good. Thank you. Who is the next one? Which the number is? 13 or 14 or anything, or nobody wants to say anything?
It might be me, but I'm kind of far down on the list, but I can see because I have 129, but maybe some.
100. Okay, it doesn't matter. Let's go to 129. Others, they don't want to present theirs. It's okay, but they should. I will get my table. 129. Okay,
Yeah.
129. That's it.
Yes. So I would say it's rather rhythmic.
Mhm.
So around 100 beats per minute because I counted like three squares.
Mhm.
And then I thought
How
it was
many? Yeah, 3.5, a little bit more than 3, so it's less than 100, but it's okay. All right.
I watched all the videos. I was trying to like see, but the axis is normal
Mhm.
because of the positive lead 2 and also AVF.
Okay, that's okay. One, lead number 1 and AVF positive, so it means normal. And if you are looking at AVL, the AVL relatively, this almost equiphasic, so you can go for 60, for example, or maybe a little bit less than 60, but it's close to 60, okay?
Okay.
All right.
And then from what I could tell, every P wave is followed by QRS.
Mm-hmm.
And also the QRS is narrow, I think.
Mm-hmm.
Um,
What about the width of the QRS?
maybe it's a bit wider.
1, 2, 3, 4, 5. It's okay. It's 0.2. No, it's not wide.
Okay, yeah, so it's normal, yeah.
Okay.
And then I see some ST elevations
Mm-hmm.
in V2 specific and also V1 and V3.
Mm-hmm.
So I came to the conclusion, I think, that it's like an anterior MI, but
No, 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 no. This is, as you see here, this lead, they attach to the right side. Okay.
yeah,
They attach to the right side. This is the right side, not the left side. So
okay.
what can you see here? We do have ST elevation, lead number 2, lead number 3, and in AVF. Which ST elevation, the biggest one?
Uh,
Lead number 3. Okay.
okay.
It looks like you do have an inferior STEMI, but
Yeah.
because lead number 3 has the biggest ST elevation, you have to think about a right ventricular ischemia or infarction. This is why they put a reverse. So it's meaning that you are not placing the V4 on the left side. They're placing the same position that you should have on the left on the right side.
Okay.
All right. So that's a right ventricular STEMI.
Okay.
Okay. That's a tricky one, I know, but this is how it works.
Yes.
Okay. All right. Wait a minute. I try to see. Okay. Now you don't see it, and I checking who is okay. We do have okay. For example, let's see, Kili. Hmm? Gilly, please. Or Coralie. Well, if not, let's go back to the beginning and we will evaluate the ECGs what we have. Okay, so now others, they don't want to see anything, it's fine. That's it. Okay, yes. Now, let's go back. What was the last one that we do see? I think that, no, it's not the last one. I think that was the last one in 112, yes? Let's go a little bit further. Okay, for example, 104. I think we had 104, yes? Somebody should tell me. I have no idea whether we had 104 or not, but possible not.
I don't think so. I had 103, and then after me, I think it was Muniba.
Okay, oh, it's yours. Okay. Okay, let's see. So somebody written that the microphone doesn't work, but how can you take the midterm if your microphone doesn't work? So you have to fix this one, or you have to log using your mobile. You can do it as well. And this way you will have a sound and you have a picture as well. So you can use your computer and I can hear you. So you can log in twice. It doesn't matter. All right. So that was Coralie. All right. Okay. Yeah, the headphone is not here. All right. Now, let's see, Zoe. It's yours. Zoe.
Okay. So I'll start with rhythmicity.
Mm-hmm.
So it appears to be rhythmic,
Mm-hmm.
based on the rhythm strip we can
Mm-hmm.
see. And I think the heart rate is around 75, 80.
1, 2, 3, 4. A little bit. It's about 4. It's 75 is fine. It's okay, good.
Hold on. Sorry, I'm like writing my notes in the meantime. Okay, so yeah, rhythmicity. Let's see the P waves. I can see P in lead 1, 2. So I think they appear before every QRS, and every QRS is followed by a P wave.
Mm-hmm.
So that is normal. In lead 2, it is positive, and in AVR, it is negative. So we know that it's a sinus origin. So we have a normal sinus rhythm. As for the axis, in lead number 1, QRS is positive, and AVF also positive. So it's a normal axis, and lead number 2 is the tallest. So I think it is around maybe 60 degrees.
Between the 1 and 2, you can see it, and lead number 3 is about equiphasic, as you see, a little bit positive, but you can see around 30 or 40. That's okay.
Okay. So that's the axis. QRS appears to have a normal morphology. It doesn't.
PR, first the PR. First the
PR?
PR. Yes, let's
Okay.
concentrate on the PR. And it looks like the PR is starts here. It's almost on the line. And it's somehow this one. I assume that is a little bit wider, about 1 millimeter. So it's meaning the O24. So I think it has a first degree AV block. Okay. So you have to measure the PR interval as well. Okay. Go on.
Okay, I was just writing it down. So let's see. ST elevations, I can.
First, the size of the R wave. Okay,
Okay,
let's
okay.
continue. And the morphology, the P, that's normal. I didn't see
Yeah.
anything. It's not wide, it's not tall, so it's not any kind of atrial hypertrophy. The R wave, if you look through all the way, it's not high in
Yeah.
2 or 3, and it's in R is not big in V2, V5 or V4, nothing. And the S is not too deep in V1. Now, the criteria for a left ventricular hypertrophy, if you summarize the S wave in V1 or in V2 plus the R in V5, and if it's bigger than 35 millimeters, that's a left ventricular hypertrophy. And this is not. Okay.
Okay. Okay. So the R waves are normal.
Yes.
So now should I talk about the ST elevation?
Yes.
Okay.
Pathological Q wave, pathological
Okay,
Q wave.
pathological Q waves. I think they appear in V1.
No,
No?
no, no,
Okay.
because you do have an initial R. As you
Okay.
do see here, you do see an initial R wave right here, okay? And only one lead that you do this kind of alteration, and that's lead number 3.
Okay.
But as we said, one lead doesn't mean anything.
Not enough. Okay.
Mm-mm.
Okay.
So there is no pathological Q wave, all right?
So ST elevations.
Yes, finally, ST
Yeah.
elevation.
I can see it in lead number 2,
Mm-hmm.
in lead number 3, and also AVF.
Mm-hmm.
So I think that's already indicating an inferior STEMI.
Mm-hmm.
And if I look further,
Mm-hmm. And immediately, if you do see ST elevation in 2, 3, and AVF, it's meaning that inferior wall. You are searching.
ST depression.
Uh-huh.
Okay.
In the anterior lead.
Mm-hmm.
And what does it mean if you do have an ST depression in the anterior lead?
It's a posterior inferior.
Exactly,
arch.
because that's a mirror image of a posterior STEMI. All right. So if you are looking at, for example, this is the typical sign for having a STEMI, all right? And the mirror of it, it should be, well, if I can draw it, oops, something like this. All right. So that's a mirror image. So if you do see ST depression in V1, V2, V3, or at least 2 consecutive leads, you can see that this is an infero-posterior STEMI. All right.
Okay.
Okay. Okay, I delete it, and I'm going to, that's it. It's 106, and I think it's, let's have maybe the next one. I try to Muniba.
Yes, sir.
Oops, yes, that's it.
Okay. So right off the bat, to evaluate rhythmicity, I think this is regular, because we're seeing about, we would say, 5 spaces between the RR intervals. So it's roughly around 60 BPM.
Or a little bit
Oh yeah,
less,
here this one
because
is 6,
5.5, 5.5. So
5.5,
I
yeah,
would
almost
say
6.
it's less. Okay.
Okay.
So it's around 50s or so. So it's bradycardic. Okay.
Yeah. And then from there, if we want to just determine if this is a sinus rhythm or not, we look at leads 2 and then AVR. So lead 2 here, we can see that there is a positive QRS complex here, and then AVR is a negative QRS complex. That's normal. So this is a sinus rhythm. Then we evaluate the electrical axis. So lead 1 and AVF both So lead
Mhm.
1 is positive, AVF is also positive. So we know that this is a normal electrical axis. We can see that, lead 3 is the largest. So,
No. Lead
oh, wait.
3 is equiphasic. This is what
Oh,
I
yeah,
wanted
lead
to
3
show
is equiphasic.
because the positivity and the negativity are roughly equal. All right?
That's true. So we would say, again, it's about like 30 degrees.
Correct. Very good.
And then now we're going to look for the P waves just to make sure that they're there in almost all the leads. And we can see that the P wave is present in all the leads, so there's no issue there. PR interval is also normal. And then the QRS complex is narrow. I'm not seeing
Good.
any
Very good.
problem there. I am, however, seeing, I believe, a ST,
Pathological Q wave.
pathological Q wave in, one second, in lead 3 and in AVF.
Because it's wide, it's 1 millimeters or so, or a bigger one. And in this case, that looks like is a normal range because it's not exceeding 1/4 of the R. But if you do see in 3 and AVF, it's okay. And especially what else you can see, not only the pathological Q wave, but
The ST elevation.
ST elevation as well. So it's meaning
It means that there's, one second, I think it's like was it posterior STEMI?
no. 2, 3 AVF. If you are looking at the hexaxial system, that's an easy way to determine, especially, all right, the position of the MI. All right, that's the simple one.
Yeah,
If you
inferior
do
then.
see this one in 2, 3 and AVF, that's an inferior, all right? This is inferior. If you do see something in AVL, all right, or in lead number 1, that's a lateral or high lateral, all right? Now, in the chest leads, if you do see for, let's see, V1, V2, V3, V4, V5, V6, that's a septal, okay? That's anterior, all right? And this is going to the lateral, all right? This is V5, V6, and together with 1 AVL, this is a lateral, all right? That's a position. So a little time, it takes a little time, but you will be very familiar with these positions. Okay, so now we do have an inferior one. Now, if you do have an inferior, sometimes you can see something in V6, V5, but it's not high. So that's the elevation. You have to have a bigger one than 2 millimeters in the chest leads. And this is not. So
Yeah.
we do not have. It looks like as a Q wave is very pronounced, but it's not bigger than 1/4 or 1/3 of the R. So I don't think any kind of lateral involvement occurs right here. One and another one, if you do have inferior, right? If you do have inferior, you have to search a ST depression in V1, V2, V3, V4. There's none. So it's meaning you do not have an inferior posterior MI, only you have a inferior MI. Okay? Clear?
Thank you. Yeah.
Good. Okay. Let's see, and let's move on. I think the next one is Victoria, yes?
Is it okay if I ask a quick question before we go?
Why not? Anybody can ask question.
It was about the previous tracing
106, yes?
regarding the inferior STEMI, because I remember, I think in your videos you mentioned that we can kind of detect if this was like a previous infarction or if it's ongoing. So how do we know if it's currently like new in a way, or if it's an old infarction that happened before?
Okay, very good question. Basically, if you are a physician, that's a very easy one because you do see the patient and the patient complains of pain and showing the typical sign of MI. This is what you can diagnose immediately. But if you do not have any anamnestic sign on the patient, there are some clue that you can use it. First of all, if you remember what we had, I draw it, okay? Now, first, when we do have an MI, when you close the coronary, first, very quickly to the ischemia is reaching a lesion. That's the sign of the lesion, that be the ST elevation, okay? This is what we call as a hyperacute. All right, this is a hyperacute, so it's an ongoing and situation that relatively is right away. So it's a couple of minutes, or that's the time when we do have this ST elevation. Later on, what will happen? If you close the coronary and the further area of the coronary that's supplying relatively doesn't have enough oxygen, so it's meaning the necrosis starts to develop. So we do have to develop a Q wave. And what we do have a Q and an ST elevation. Okay, this is what we have. So Q and ST elevation. Here we had only ST elevation. Later on, what will happen? The Q is will deepening, and later on the ST goes back a little bit, and the negative T is developing. So relatively, what you do have a Q, ST, and a T inversion. It's meaning that, for example, okay, the coronary comes from here, and this area is necrotized, okay? It's completely necrotized. That gives you the Q wave. This area that I do have here, maybe I'm using a different color, that's be the sign of the lesion. And if you get further close to the coronary, this area is ischemic, okay? This area is ischemic. That meaning we do have a sign of necrosis, okay? A sign of necrosis. We do have a sign of lesion, all right? And we do have a sign of ischemia. Okay, and this still called as a acute. So this is an acute phase. It's meaning this acute, it's lasts for hours, from hours to maybe days or so. And after about 4 days or so, what will happen? This ST elevation, this lesion, it's a clinical death. So the cells will die, or true ischemia is healing. So what will happen? We do have only two different things. The Q is there because the Q won't do anything because necrotized, but you do have only two signs. You have a Q wave and you do have an inverted T wave, okay? And that is called a subacute. Now, a subacute means it's from several days or week or so, okay? And later on, after months or years or what you have, if you are lucky, especially, whatever the Q is there, it won't change, but the T is going back to the normal or close to normal. Anything can happen. It stays negative, can be biphasic, can be anything. It's meaning that you still have problem with the coronary circulation. So this area still can be ischemic, but this is what is called the chronic or definitive. Okay, this is what is a chronic or definitive phase. So this is how you can guess whether the patient had a previous infarction or not. If you do see only a Q wave, that's okay. That's meaning as a chronic one. The easiest way to detect, for example, side by side a chronic and an acute one, if you do have, for example, a pathological Q wave in lead number 2, 3 AVF, and you do see ST elevation, for example, so I draw it, okay, maybe it's not the correct one. So you do see a Q wave, and in 2, 3, okay, 2, 3, all right, and AVF, this is what you do see. There's no ST changes, okay, no ST changes. And you do see, for example, in V1, something like this, okay, as a keyword. or something like that. So you do see ST elevation, and you can see pathological Q wave as well, doesn't matter. So it's meaning that you do have an acute ongoing MI in the anterior anteroseptal area, and you had an old MI in the inferior. But of course, if you do have the anamnesis, you will see this patient had an MI earlier.
Okay, thank
Was
you.
I clear?
Yes, thank you.
Okay, now what was the last that I wanted to show you and give to Victoria?
Yes.
Okay, let's see which one that I should. Okay, 118. I like 118, or shall I go for this 109? Let's see, 109. Okay. Yes, 109. That's great. We haven't had this one, yes?
I don't think so.
Okay, now you have it.
Okay. It's rhythmic
Okay.
and it's about 1, 2, 3, 4, 75 beats per minute.
Well, a little bit less, because 1, 2, 3, 4, 5, a little bit less than
Okay.
5. So it's okay, 65, it's okay.
Okay. And then try and see. Okay. So lead 2 is it equiphasic?
Okay, you can say it. Lead number 2 looks like equiphasic, but you can start here. 1 is positive, AVF is negative, 2 is equiphasic, so the axis is minus 30.
Okay.
Yes?
Yeah.
Okay.
And then let's see.
P wave, PR
P wave,
interval,
yeah.
that's all. Okay. We do see P wave, and maybe you don't see because very noisy in lead number
Yeah.
2. It's very noisy, but you do see in V1. Okay, the next one, if you want to find a P wave, go for the chest leads. If you do not see nicely in the limb leads because something happened, go for the chest leads, and you do see that, yes, you do see P waves. And first of all, this rhythmic one, so I assume that it has to be a sinus rhythm. Okay.
Yeah.
Now
And
the PR interval, because the morphology is okay, it's small, we do not see it.
I think it's okay. It's hard to see.
Yeah, it's okay, it's normal. This is what I draw, it's 0.2,
Yeah.
because this is the beginning of the QRS, and this is the beginning of the PV. So that means that PR interval is normal. Next one, the QRS complex, is it wide or not?
It's I think it's okay.
No, it's not okay. That's wide.
It's wide.
It's wide. It's very wide. See here, for example, coming here and ending here. That's wide.
Okay.
All right. Now, immediately, if you do have a wide QRS, what is your thought?
If it's wide, then it's some kind of block.
Intraventricular block. Okay. Now you can go immediately. Which one?
The right.
Don't ask it. Say it. Because you do see that the ventricle activation time is elongated, or you do have a wide R wave in V1,
Yeah.
okay? And you do see a wide S wave in lead number 1, or you can go for V6 or V5, yes? So
Yeah.
it's meaning that's a right bundle branch block, a complete right bundle branch block. So far it's okay. All right, let's continue.
And then I can see, is that in inverse T wave in
But before the T, we have to talk about the ST segment. All
Yeah.
right. Or pathological Q wave. So pathological Q wave ST segment. This is how you go.
Um
Okay, now let's see. In lead number 1, there is no Q wave, not at all. All right, I do not see. AVL you do see, but it's not deep, and only in AVL. All right, and you don't see in V5, V6, so it's no lateral for sure. Now, if you get close, okay, if you get closer to, for example, lead number V1, that's a
Yeah.
little initial R you do see here. And in V2, well, it can be LQ wave because I do not see any initial part, okay? That can be, and this is not pathological for sure. So I do not think so that we do have pathological Q wave. But now you can go for the ST segment.
Yeah.
All right.
Yeah.
And because you do see an
Elevation.
ST elevation, I try to, okay, reduce the size. You do see ST elevation, all right,
Yeah.
in V2, V3, V4, all right?
Yeah.
And you can say that this is a
And the right ventricular.
what is the right? No. Right ventricular hypertrophy or anything, it goes for the big R and deep S, all right. But we
Okay.
said that's a RBBB. Okay, that's okay. RBBB. So the right bundle branch block we had. All right, that's okay. All right. And because we do have an ST elevation in V2, V3, V4, we do have a anterior STEMI. All right. This is STEMI. Okay.
Yeah.
Now, there is an alteration of the reposition due to the bundle branch block. However, that is going to cause an ST depression and T inversion. Okay,
Yeah.
the secondary ST changes usually is a sign of ischemia, so ST depression or T inversion. That can explain here what you do see in V1. But
Yeah.
ST elevation never, okay, ST elevation never could occur.
Okay.
And that's already, you have to say that's an anterior STEMI, what we do have here. Okay.
So anterior STEMI is when we have an inversion of the T wave.
Yeah, inversion and ST depression, something like this. I try to draw it. Okay, something like this. That could
Okay.
be the secondary. Now, and based on the axis, it's minus 30 or close to minus 30. But if you had bigger than minus 30, for example, if I say that, oh, lead number 2 is negative, more negative than positive, that is, for example, minus 40, immediately you have to think about the left anterior hemiblock, okay?
Okay.
So if it's close to minus 30, you can go for the left anterior hemiblock, and together with the right bundle branch block, you can say that could be a
S biphasic.
bifascicular,
Okay. Yeah.
bifascicular block. Okay, you can go for this one.
Okay.
All right, it's clear?
Yeah.
Almost. It needs practicing. That doesn't matter. It needs practicing. I want to, okay, I'm going to share an other. Now, I think Zoe is yours.
Okay, I will try. 1 second, I just have to.
That's an easy one. That's an easy one.
Oh yeah, okay. I'll
All right.
believe it.
Believe me, you can solve it.
Okay, so let's look at the rhythmicity first. It appears to be rhythmic, and I think the heart rate is a little bit less than 100.
1, 2, 3. You can go for 100.
100,
Okay.
okay. Okay. So it's a normal heart rate, and I can see P waves in front of every QRS, and every QRS is followed by a P wave. P is also positive in lead number 2, and in AVF, it is
AVR is negative, so it's a
AVR
sinus.
negatives. Yeah, sorry. So we have a sinus origin. QRS.
The morphology of the P wave is okay,
Yeah.
all right, okay. PR interval, the next one. Don't forget it. You have
Yeah.
to go step by step, okay?
Okay.
PR is normal again,
Normal.
okay? Now you can go for the QRS
The
complex.
QRS also normal. It is not widened. Okay, next the axis. So QRS is positive in lead number 1. In AVF, it is negative. So we have a right axis deviation. Oh.
Excuse me.
Hold on.
1 is positive. Can you have a right axis deviation?
Sorry, no.
That should be a left.
Yes.
And AVR is positive. So what does it mean?
Hold on.
I'm holding.
I'm getting brain freeze. AVR is positive, so it's closer to minus 30.
Minus 60.
Oh, okay, yeah.
Minus 30 is perpendicular to lead number 2. Okay. So that's a extreme left deviation.
Yeah.
What does it mean?
Because the normal QRS, it's most likely left anterior hemiblock.
Yes, that's it.
Okay.
That's a left anterior hemiblock. Immediately, you can say that's a left anterior hemiblock. Okay. From the axis. Okay. Now you can go for the QRS complex. Okay.
Okay. So I mean, it appears to be normal.
The width of the QRS is normal. All right, that's fine.
Yeah.
Don't be surprised if something is normal. Okay.
Okay, next, we can look for should we look for Q waves, pathological Q waves first?
Go for the pathological Q wave.
Okay.
Yes. You can go for 1.
1
No.
doesn't have any.
2,
2 also
no.
not.
3, no, because it's starting with the initial R. Okay.
Yeah.
Nothing. AVF, no.
So then ST elevation.
No. You only finish with the limb leads. You can go for the chest leads.
Okay. So the chest leads, I think there's a pathological Q waves in V1 to V3. So
So you can go for the ST segment as well, because you see it's the sign of necrosis. In V1 to V3 and V4, you do see ST elevation. So again, you do have a
anterior infarction.
Exactly, an acute anteroseptal STEMI. Okay, an acute. This is an acute because you already have necrosis, sign of necrosis. Okay, but nothing else. Okay, now still stick to this R or the QRS complex. What can you see here?
I think we see tall R waves. Or
No, it's not tall. The S is too deep. All right. What does it indicate?
Hypertrophy?
Which one?
Right?
No.
Left?
Yes. Oh, I confused. Yes, right ventricular hypertrophy.
Okay,
Because on the left
that's
side,
what I
you do
thought.
see exactly the opposite. So that's a right ventricular hypertrophy. This is what you can see. All right. Okay, good. Now let's move on. And I hope I can find no, not that. I want to show. Okay, that's all right. That's all right. Ah, that's a tricky one. That's okay. I have to Okay. Yes. No, I think it's Muniba.
I don't think she's here anymore.
No, she left. Pff, okay. All right, Victoria.
Yeah.
It was enough for her.
Yeah. Will the midterm be like this? Like we will get just like a random one? And then,
Yeah, you will get a random one, but it's common to everybody. So I'm using the official one, official ECG. So won't be difficult one. Believe me, these ECGs is more difficult. It's only one thing, by picking up an ECG and having no time to be prepared. That's a good practice. Of course, you will have time, but maybe you have 5 minutes or 10 minutes or so, and you have to present it. But this is how the clinician should work. When you get the ECG, you have to evaluate immediately.
yeah. But like how do I like pass? Like do I need to answer like all of the questions correct next Friday, or is it okay if I have like some small mistakes or
You see, whoever stayed here and presented ECGs, they are good. I believe that three of you, Zoe, Muniba, and Victoria, you can get an offered mark for the midterm. You don't have any problem with the midterm. Victoria, you still need to practice a little bit,
yeah.
and Zoe and Muniba as well, but less than you. And it's okay.
Yeah.
I already graded you, but don't worry. Don't
Yeah.
worry. You can solve it. You need practicing. This is what we are doing right here. And because you were here all the time, I counting on this one as well. So
Okay. Um. Okay. So
rhythmic or not?
yeah. Or I mean, I would. Yeah, it's the perfect. I mean, like like the beats are coming, but not really. Not all of them are like at the same. So I don't know. Like, do I count that as not rhythmic or rhythmic? Because like
Look,
there's.
I know a guy, if it's a little bit nicer than a devil, it's okay. But no. All right. This is a rhythmic for sure. All right. This is a rhythmic. You can see it.
Yeah,
Yes?
it's the rhythmic.
A
Okay.
rhythmic. Okay, good.
Yeah. Um.
The heart rate, all right, is difficult, but you can see it is
Friday.
1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, about 60. It's okay.
Okay.
Here you can see the 1 second interval. It's a darker line. Okay, good. So
Okay.
60. It's okay. It's normal.
Yeah. Okay.
Next one.
And then so it's already a rhythmic. And then
It starts to blink something in your mind.
yeah. And then the axis.
Well, you can go for the axis if you wish. Doesn't matter. Okay, go for the axis. Lead number 1 is, looks like, positive.
Yeah.
AVF is negative. Lead
Yeah.
number 2 is negative. So you can go for an extreme left deviation. Okay.
Yeah.
All right. Go on.
And then do I need to say like the degrees or
No.
okay.
It's okay. I already said that it's around -30, a little bit more than -30. And if you go for the AVR, it's equiphysics, so -60. It's okay. So it's an extreme left deviation. Doesn't matter. All right. Extreme left deviation. Which is the next one?
And then do we do the QRS complex to see if it's
No.
what?
This is why I will send you my scheme how you should go through the ECG.
Yeah.
I would start with the P wave all the time because
Oh,
the
right.
QRS complex start with the P wave, PR interval, QRS, and usually I like the evaluation of the axis when we are talking about the QRS complex because you are evaluating and you won't forget anything. But if you
Okay.
start with the QRS there's the axis, immediately you are missing the P wave.
Yeah.
All right. So
So
first rhythmicity, next heart rate, and next the P wave, because
okay.
you have to say that
Yeah.
sinus or not.
Okay. I there m- I don't think there's a
Okay,
P
P
wave.
wave, very good. There is no P wave. Or if you do see in lead number 3 a lot of waves, or in V1, if you do not see nicely, you should go for the V1.
Okay.
And immediately you see that there is no P wave, because the P wave should be a discrete run shape. Okay.
Yeah.
And this is not. So, arrhythmia,
Yeah.
no P wave.
It's pathologic.
What is this? What did I say? If somebody wakes you up in midnight, what you say?
Is it Van der Branch block?
Nope. No. Atrial fibrillation.
Oh, right.
Immediately. All right, because that could be a big mistake if you are a physician and you are not, let's say, discovering an atrial fibrillation. Immediately, let's assume atrial fibrillation. Of course, if you feel the pulse of the patient and you feel arrhythmic, completely arrhythmic, you can say that's fibrillating. All right. And
Okay.
if you do see, that's much easier to discover atrial fibrillation based on the pulse than looking at the ECG. Because if you're looking at the ECG, you are trying to find a P wave or something. And you want to force yourself that can be a P wave, because sometimes we don't see P wave and so small P wave, but that's rhythmic. If you do have sinus written, that's rhythmic. If it's arrhythmia and you do not see nice discrete P wave, say it atrial fibrillation.
Okay. Is it always that, like, if I don't see a P wave,
Yes,
I assume
but
it's atrial
arrhythmic.
Okay. Yeah, it needs to be
Because
arrhythmic for it to be atrial fibrillation with no P wave.
exactly, it has to be arrhythmic. It has
Okay.
to be arrhythmic. Okay, go on.
So after then I do the QRS.
Uh-huh.
Okay. It's but for the QRS, do I check the limb leads or the chest leads?
Doesn't matter which
Okay.
lead. You can check any leads, but the QRS, the width of the QRS should be normal in any leads. But if you have here, I will say immediately, especially here,
Yeah,
this
it's wide.
QRS is not normal, it's wide.
Yeah.
Okay, that's QRS is wide. Okay, that's QRS is wide.
Yeah.
What does it mean?
It's a interventricular block.
Yes.
Okay. And how do I check
No.
again? Like how, if it's the right or the left side?
Okay, what did we say? Whenever you do see the wide R complex, this is
the
in
right.
V1 and in V6. This
Yeah.
is an R. No, that's an S. There's a QS. Okay, it's a deep QS complex. And here you do see the R. And here you do see the R. See? And this is the left side. So
Okay.
what you have?
It goes from left bundle branch?
Yes.
Okay.
So if you do see this Q widening of the QRS complex, and you do see QS complex in V1, V2, and especially big R wave or wide R wave, or in, for example, V5, V6, or in 1 or 2 or AVF, you should say immediately that's a left bundle branch block. Okay?
Okay, yeah.
All right?
Yeah.
Well, go on. We haven't finished.
Okay, so after QRS, what do we check after? Sorry, I don't remember.
Pathological Q wave, ST segment.
Okay. We have
Okay, let's go.
ST depression? No.
No, Q wave
Q wave.
first. Q wave first. Okay, here we do have a Q wave in lead number 1, but it's okay. In lead number 1, we have V5, we don't have V4, V6, we don't have, but we do see in V1, V2, V4, we don't, but we do have R regression. Yes, we do have R regression. Can you see this R regression?
Yeah.
This R is not propagating properly, because normally from V1 to V3 or V4 is getting bigger, the biggest one in V5, and the ST is getting smaller, and the transition is between V3, V4. And
Yeah.
here,
It's the other.
immediately V5 and V6 is getting. So we do have pathological Q wave all the way in the anterior leads, okay, especially in the lateral one as well, in V5 as well. So what does it indicate? That's a tricky one. This is what I wanted to show this ECG tracing.
Is it some kind of maybe not necrosis of the heart?
Yes, that's not a necrotic sign, because left bundle branch block itself causing pathologic QS complex all the way, okay, all the way in the anterior lead.
Okay.
All right. So
Yeah.
this is why it's difficult. It's very difficult, basically, to diagnose an MI in case of left bundle branch block.
Yeah.
Now, I will show you, maybe on the next time, I will show you, I have to find it, a case when we had left bundle branch block together with an MI, anterior MI. Yeah, but this is not. So first you have to think about, okay, I found it and I will show it right away. So, but if you do have a left bundle branch block, for sure, you can expect QS complex all the way. And when you do have, for example, in V6 or V in lead number 1, that's an ST depression. See, ST depression is not an elevation. If you had something like this in, for example, in V6, now that can be a STEMI as well, but here not. And if you do have an extreme left deviation, when you do have a left bundle branch block, that you can explain, yes, this is due to left bundle branch block. So you don't have anterior or posterior, because left bundle branch block means both are missing. Anterior and posterior is missing completely. Okay?
Yeah.
I show, wait a minute, okay. Now, Zoe, are you here?
Yes,
Okay, it's yours.
still here. Okay, so I'll start with the rhythmicity. I think it's rhythmic.
Yes, it is.
There are around like 5.5 boxes.
Well, we can go for it. I tried to check it. Okay, this 1, 2, 3, 4, 5, 6, 6.5. 6.5.
Okay,
So it's less
so
than 50 for sure. All right. So
okay,
it's very
so
cardiac.
we have bradycardia. Looking at the P waves, I can see them in 1, 2. I'm not sure if I can see them in, or maybe it's merged with the QRS complex in.
No. It's here.
okay.
It's
Okay,
here.
okay.
Here. You can see that's a discrete P wave in lead number 2 is positive, AVR is negative. Okay, you can assume that this is a sinus P wave. Okay, that's fine.
Okay, so we have sinus bradycardia. And then if we look at P morphology,
Yeah.
appears the
I would say it's normal.
yeah, okay.
Don't expect too much. That's the
Okay.
normal.
Okay, so normal P wave morphology, the PR interval, however, seems to be longer to me.
Well, 1, 2, 3, 4, 5, 6, 7. Yes, it's wide. Okay, that's wide. All right. So far we had the PR interval is wide. Okay, good. Go on.
Next, we can look at the QRS. QRS is widened, I think.
Okay, wide. Okay. Yes, you can see very nicely that the QRS is almost 0.2 second. So it's meaning wide. What does it indicate?
A bundle branch block.
Which one?
It's a right bundle branch block. Is it not?
Whenever you do see the wide R, the block is there. Can you see wide R wave in V1?
Yeah.
Wide R,
Oh,
this is
sorry. No.
that's a QS
Yeah.
complex. This is not a R wave.
Okay.
So where can you see the wide R wave, the notched R wave? In
V6.
V6, V5. Look at this one, is a sitting rabbit.
Yeah.
I don't like this phrase, but it's a sitting rabbit. Okay, so
Left
yes, that's
left
a
bundle branch.
left bundle branch block. Okay, good, very good. Now, the next one, pathological Q wave.
Mm-hmm.
You
I
can see it.
Yeah.
V1,
V1.
V2, V3,
Mm-hmm.
V4 not because and V3 no because that's the initial what's that initial R wave you can see here. But for sure, what do I see here in V5, V6?
ST elevation.
Yes. It's meaning that you do have a left bundle branch block plus an anterior STEMI.
Okay.
Now, this is the typical sign of a secondary STT changes. Okay, this is widening of the R. This is a left ventricle lead number 1. Okay, and ST depression. That's okay. That's a typical for that one. But here, what you do see here, especially, it's not. So this is why you can say that this is a left bundle branch block with a anterior STEMI. Now, if you go for that, because the PR interval is elongated, and we do see left bundle branch block, so we do have an AV block plus a left bundle branch block. How many fascicles are missing?
2.
3.
Okay.
Anterior, posterior, AV.
Okay.
Okay, so when you do have a lab, if you look at the trifascicular block, the trifascicular block, you can find that mostly is accompanied with a right bundle bifascicular block plus an AV block. But if you do have an AV block plus left bundle branch block, you can see this trifascicular as well.
Okay.
Okay. Good. Very good. Okay. All right. Stop recording.